please do. There are a number of colleagues that I'll probably pull into the conversation as we go along, because you guys will know more than me in terms of those that have already got up and running with vaccinating people already. So I'll pull you into the conversation. I'm just going to really start off by sharing a few slides. We've just pulled out the flow chart bit of the mobilisation guidance that NHS colleagues have shared with you already. Today's really just going to be a discussion about mobilisation, a chance for you guys to have a conversation about that, ask questions of each other, and really try and unpick some of that and yeah, just get a bit of a lay of the land. Thanks to those that fed back where you're at with things, and also kind of your kind of status in terms of estimated numbers and things like that. I know you've got to send those spreadsheets back to colleagues in NHS. I believe Andy and Sam are on the call. If you want to say hi, please do. They're the COVID-19 vaccination leads from an NHS perspective, who will be collating all the information that you've pulled together on your spreadsheets in relation to the estimated numbers of people and where they're located. I don't know if Sam or Andy want to say hi.
Yeah, hi there. I'm Sam Harris. I've been redeployed since the end of last year to work on the COVID vaccination programme. My background's primary care, so I'm very much working with primary care colleagues for the PCN deliveries via LVSs for vaccinations.
Fab. Hi, Sam. Thank you. Andy, did you want to say hi?
Yeah, hi, Andy Briggs. My background's also primary care, but I come from general practice, and I've just been brought in to help out with this programme.
Brilliant. Thanks, Andy. So in terms of today, I'm just going to go through, like I say, we've pulled out the flow chart bit from the mobilisation guidance, and just thought we'd just talk through that, and then I was going to bring in colleagues from across the southeast that have already started mobilising, just so that they can talk a little bit about how they've approached it, and then people can just come into the conversation as and how you feel you want to at that point. Does that sound okay? Next slide. So, as I said, this is just taken from the mobilisation guidance, but there are lots of words on the flowchart in there. So we've just pulled out the kind of key headline bits in terms of kind of preparing the way with your NHS colleagues locally. So hopefully you've started to have conversations with your CCG partners and local NHS colleagues on the ground, in terms of kind of making connections. Hopefully if they've made connections with you on the local authority level, MHCLG advisors will have sent a letter from MP Robert Jenrick back on the 12th of March that outlined how local authorities should work with their local health partners to consider the alternative means of delivering the vaccine to homeless settings, and so this should already be kind of in the minds of everybody locally, and hopefully that will have filtered down to you all in your local systems. There's kind of real emphasis on making sure that a range of agencies are involved at a local level, so not just local authorities but all the partners that you're already working with, and particularly with people experiencing homelessness, as you well know, need a range of people so that we make sure that we reach everybody that we can, and making sure that in terms of the sites that you're looking at, refuges as well as hostels, hotels, and all of those things, as I'm sure you are. Obviously, our health partners really need your help in estimating the number of people in this cohort, and that's what the spreadsheet's all about, so that you can make sure you get as many people and they know how many vaccines they need and so on to help support that. And really, again, in terms of working together to work out who that delivery team and what that delivery team might look like, then you'll need to be working together to kind of draw on your existing outreach teams that you've got locally, specialist healthcare practices where they are there, your local voluntary sector organisations, substance misuse services, utilising those. But it also provides an opportunity in terms of that of the other things that we can be looking at when you are rolling out the vaccination mobilisation, in terms of making use of every contact that you've got with people. And so thinking not just about the vaccination in front of you, but thinking about what other health checks and screening could be offered at the same time. So making every contact count and thinking about that as well when you're doing this. Next slide. So the next phase on that kind of flow diagram was the kind of engagement and the opportunities. So it's just the stuff around digital, obviously making sure that once you do mobilise that there's signal in the place where you're setting up so that you can access Pinnacle and stuff for your mobile outreach teams for both clients, and you've got access to Wi-Fi for both clients and staff. And in terms of that kind of engagement, and hopefully some colleagues will talk about this when they share some of their experiences, but in terms of maximising uptake, how you kind of engage and involve people with lived experience and community leaders and partners in supporting individuals to make informed decisions and choices about whether or not to take up the offer of a vaccine, and helping people to prepare for that is going to be crucial. So we've got loads of resources. We've kind of grouped all of the resources that are mentioned in the mobilisation plan and everywhere else around different things that you can use to help prepare people to taking up the vaccine, and then kind of information about what it is and all of that, so you can help with those conversations as you go forward. Obviously, one of the key things is about maximising the opportunity to get people GP registered, and other opportunities around different health interventions as well at the same time. Next slide. And then the last kind of bit on that flow chart is just embedding the process. So there's information in there about the registration process, and that it can be paper based, and that they don't have to have an NHS number, and if they're not registered for GP and things like that is not a precursor to not having the vaccine. There are ways around that. And for individuals that refuse to provide personal information, again, that shouldn't preclude them from being offered the vaccine. There's ways around that as well. In terms of the second dose, so again, in the guidance, it talks about looking at ways of maximising the opportunity to enable people to access that second dose, and there is scope for giving that second dose sooner than the 12 weeks that is there for the general population. So for things like, so for Pfizer, there's a minimum 21 days between the two doses, and then for AstraZeneca and Moderna, there's a minimum 28 days gap between the two doses. So there is an opportunity if you feel that individuals may not be able to access the vaccine in 12 weeks, you could look at other ways of vaccinating sooner if that's going to be of benefit to the individual. Next slide. I think that's it, isn't it? Yeah. So I thought it'd be useful now just to bring in a few colleagues that have already mobilised and let them talk about kind of the approaches they took, and to hear from them about how it went and some of the challenges and also some of the opportunities that it afforded. And I don't know if is Alex and colleagues from Hampshire on the call. Hi, Alex. Are you happy to have a talk through a little bit about what you guys did?
Yeah, I guess we were quite early. I think we just made a decision pragmatically that this was a high risk group, and we, to be honest, cracked on before it was fully sort of accepted by government guidelines, because we could code people that we thought were at risk, and that was our gift. So we decided to do that. And then we had a go, and we realized quite quickly the identification of this group was probably the hardest bit to do. And we needed really very strong support and cooperation with, I suppose, two sectors really. One is we have a couple of homeless projects in Winchester, for instance. One's called Trinity, which is a day project, and one's called the Night Shelter, which offers sort of nighttime accommodation. So they see quite a lot of the homeless that come through, and they're aware of them. And then also the temporary housed in hostels, which are also quite a high risk group because they are often a dozen or 2 dozen in any one location, and they don't stick to any of the rules from my point of view. So so those are the two groups that we targeted really, people that were on the streets or put in hotels, but still at risk, and also all the hostel sort of groups. And so we liaised very closely with the housing support workers from those hostels. We identified which hostels we wanted to do, and also the two homeless projects. And they gave us the lists of people that were on their books, as it were, and we had really good cooperation with them. And that gave us a list of about 100 people. And we found pretty early on that a lot of them were registered with us already, because we've got that arrangement with our homeless project. So we cover them from a medical point of view, and that works well. But we found that a third of them, the addresses that we had for them were wrong. A third of the addresses we had for them were right in hostels, and a third of them were sort of street homeless or didn't have an address. So that was the sort of, we just needed to grapple with that and correct all that before we dived in. And then I suppose the next thing is we just decided on some dates and let everybody know that we were coming, and we let the support workers sort of educate, or not educate, but sort of get support from their residents. And to be honest, I mean, the Night Shelter, out of 11 people, they got 10 people lined up, which was amazing. Our homeless day project sort of just pulled in people ad hoc that they could, and the hostels, again, the support workers would probably round up a good 50+%. Sometimes it was 60%, but it was that sort of order of magnitude. And what was really interesting is, I think, taking the vaccine to them, which is critical because it doesn't work if you ask them to go to some hub somewhere. There were often comments of, "What are you trying? What is this, doc? Is this? Are you trying to put a chip in me?" No. This is just to get you to produce some antibodies so that if you saw the virus, you'd have a really good response to it. Oh, all right, and yeah, all right, yeah, give it to me, then I'll take it. So they would literally switch on a sixpence, particularly if they saw their peers having it. Then suddenly it became rather than, I don't want it because no one's having it, like I do want it because a lot of other people are having it. So it was a lot of peer group pressure. So taking it to the group was really interesting. In fact, I had a focus group yesterday at Trinity, and a lot of people were saying, well, I haven't had it, I want it, how do I get it? Well, you can always go up to the hub, but I appreciate that's a bit complicated. So we're coming back in a couple of weeks. Do you want to come then? Yeah, put me down. So there was that sort of change of enthusiasm, which was actually fascinating to see. So I think probably that's all I want to say. The only other practical things apart from taking the jabs to them is we didn't have Pinnacle and Wi-Fi contact. We just did it all on a paper-based system. So we did probably a dozen people in an hour, paper-based, and then took it all away and put it all on Pinnacle later, which seemed to be much more user-friendly and time efficient. I think that's probably all I'd say at this stage, but I'm happy to sort of take questions.
That's fantastic. Thanks, Alex. Does anybody want to ask any questions at this stage? And we can bring Sharon in at this as well. Sharon, if you wanted to say anything about the wider Hampshire response.
Yeah, happy to chat about it. And I'm pleased, I'm no expert on vaccine or anything, but myself and my colleague Patrick Fowler are commissioned by the Hampshire and Isle of Wight STP, and we bring health and housing together through a focus on the home. And it just made me curious, you know, and it was such good news on the push to get people up the priority list for the COVID vaccine. But it made me curious about plans for the winter too, in terms of the flu vaccination. And I appreciate it's only March, but I think it would be really useful to have a conversation here about colleagues' plans to perhaps raise this. We know that traditionally it's a group that hasn't had a great uptake on flu vaccine, and there will be lessons from previous years to reflect on, but also learning now in terms of building those relations and the model of delivery. And as Alex was saying, that sort of outreach mobile going to individuals. So I don't want to tread on toes if work's already in train, but actually I think this is too good an opportunity to miss. So it would just be great to open the conversation up. Thank you.
Yeah, I think you're absolutely right. And I think we need to be planning for that right now, and certainly using this opportunity to really look at the model and see that it's working, and use the flexibilities within the Green Book that we used before the JCVI announcement for flu when it comes for the autumn. So really good point. Thank you. Tim, did you want to come in?
No, sorry, that was an error.
Okay. Does anybody want to come in on any questions or anything? No? Tim, I did wonder if you wanted to talk about the Brighton experience at all.
Yeah, I mean,
Put you on the spot a bit.
Yeah, sorry, I've just been I can't always make it, so I've just been invited and asked if I could say a bit. It's fantastic hearing what's been happening in Winchester, and I'm not sure how applicable what we've been doing here is, because obviously we have a much larger population, so we took a different approach here. So we've done about 750 vaccinations so far of people who are homeless and vulnerably housed in Brighton and Hove. And so for us, it's been a really big project that we've taken on. We're into the 7th week of it. So the plan is our hope was to try and do about 1,000 people in 8 weeks, and then to have a week or two's break, and then to try and do your second doses in the subsequent 8 weeks. And so we're almost on track for hitting the 1,000. It's been interesting. So where we've been lucky is we already have we look after about 1,300 people who are homeless and vulnerably housed. We know there are well over 2,000 in Brighton and Hove who meet that criteria, and so we thought if we could get half of them, that would be good. And what we found is that people in supported accommodation have been easier. Really, I think partly because they're more likely to want the vaccine because they're more likely to have underlying health conditions. And but really largely it's been easier to reach them because of the fantastic teams they have in the hostels that we've worked really hard with before arriving, getting forms partially filled out and then vaccinating them. Where it's been much more difficult is in emergency accommodation, unsupported temporary accommodation, really because of the shortages in the council and the housing department. They've been unable to give us help in terms of setting things up beforehand in quite the same way. So we've gone in cold to quite a few of those locations. And so whereas for supported housing hostels, we've managed to get between 50 and 70% of people vaccinated, for emergency accommodation, it's probably closer to 30%. So that's frustrating. We're having lots of talks about whether we need to revisit those accommodations and try different routes. I mean, there's so many things that I could pull out of it, but I just don't know how applicable it would be, because obviously we're dealing with sort of a more known population. And what I would say with any of this is that what is The frustration is that so many people are only just now waking up to health inequality, aren't they? And for all of us in this meeting now, it's like, well, yes, if we'd been listened to for the last 10, 20 years, then maybe we wouldn't be in this situation now. And so it's great the commissioners are now sort of really taking note of health inequality, but what we need to emphasize to them is that to address this, firstly, it's not cheap. And so you need to give money to it. So far, we haven't been paid for the work we've done. We're doing off all of our own backs, but we have been assured that some money will come at some point. So it's not cheap. It needs to be funded well, and it needs to be built on existing relationships. And if you don't have those existing relationships, you need to build those relationships before you start projects. So there needs to be ground up aspect to it. And because we've been very successful in Brighton Hove, we've been asked to advise on how we reach other hard to reach groups in the city, and where we can see they're struggling is where there hasn't been pre-existing relationships, whether it's BAME groups or learning disability or so on. So I think the message that we need to be giving loud and clear is that health inequality obviously is important, but it's not cheap, and it needs to be built on local relationships. So there's a question about temporary accommodation outside of Brighton Hove. About 300 people have been housed outside of Brighton Hove by our council, many of them in Eastbourne, and at present we haven't been into Eastbourne. The reason for that is it's complicated, but really because doing this has had a huge impact on our team, as I'm sure you can imagine. And so we've been working crazy hours just trying to continue providing service at the surgery while still doing 3 days a week vaccinating out in the community. And we've not been given any guidance. So this has all been us setting the parameters of what we would do and won't do. And so we haven't been to Eastbourne yet, purely because we don't have the people power hours to do so, and also because we're not sure whose responsibility it is to start going to other areas and doing that. And so this is somewhere else that we could really do with people, commissioners and leaders in the council taking a lead on and having some sort of strategy as to who's responsible for who.
Yeah, that's a really good point, especially when you've got people in different local authorities and the responsibilities and all of that makes it really, really difficult to get that. I'm astounded with the numbers, Tim. It's just amazing, and the fact that you've been doing this with very little support resource-wise is even more astounding, but amazing. Any questions for Tim?
I would just add to what Tim said, which is, and I completely agree. I think this happens in a few places because there are one or two enthusiastic people that want to do this, and if there's an expectation that this gets rolled out across the area, you can't expect people to go to the nth degree because everyone's stretched. So it is about relationships and resource. It is time and people. That's all it really is. I don't think you have to stipulate exactly how it happens, because I think every area is slightly different and you have to adapt to where you are. I think there are people that are willing to take it on, but you need to gift them with the sort of permission and some backup, and then it will happen. Is my, and I think I can't overemphasize what Tim has just said. It is about all of that.
Yeah, I agree. The relationships are crucial, and I think we can see that and like you say, Tim, not just in terms of the homelessness work, but in terms of inequalities more broadly, where those relationships are there and have been for some time, you can see things fly, and where they're not, it takes a lot longer.
I think I would just add, and this is to the commissioners really, I mean, we're very lucky. We have a commission contract from the CCG, which is historic, to look after our local homeless. So that's why we've created those good connections. I think to expect people to become registered and to have open access for their everyday care, let alone this sort of program, without a bit of extra resource, a normal capitation fee for a GP will just not touch the sides because a lot of these folk are if you want to do it properly, it's very time consuming. And so if it's acknowledged and it's resourced and there is an arrangement, then I think a lot of general practice would get involved and then there'd be some cover, and then they provide the sort of flu jabs and the vaccination that is required. But it requires someone just to.
It's more intensive, isn't it? You're not going to get. Agree. Chris, did you want to come in?
Yes, thanks, Emma. This is, I suppose, it's a comment on Alex's point there. That yes, we have a designated resource in the CCG, which has proved very, very useful, invaluable, in fact, in getting people signed up to GPs and access to healthcare. And a kind of more general query, really, something that feels like a big issue for us at the moment is the kind of the spread of anti-vax propaganda, for want of a better word, people using social media and then sharing these messages. So one of the biggest barriers we've found is that we've identified people, we've offered them the opportunities to get vaccinated, but they've said, oh no, I've heard all this about how you get side effects and blood clots, etc., and that's kind of one of our biggest barriers right now. And I just wondered if that's common across other authorities.
Good question. Any?
Speaking from Brighton, you're always going to have a fair amount of anti-vaxxers in Brighton anyway, although they're not necessarily the group that I look after. But yeah, I mean, what we also find working with people in the homeless communities is that urban myth is very powerful. And so we have really struggled with vaccine hesitancy. And again, that's where relationships comes in. It doesn't work getting someone cold calling or someone who's not used to looking after this people who are living in these circumstances. So it is all about relationship. And we've had a number of people who said, I don't want it, I don't agree with it, but if you're saying that I should have it, then I'll have it just because I trust you. And that's not just me, it's our amazing nursing team, it's the other GPs, it's our admin, our receptionists. So, and it's all based on relationship. But so we've managed to persuade a fair amount of people, but honestly, some people are just absolutely unpersuadable. And what I've started doing with them is just joking and saying, you're right, I do want access to your bank details. I do want to know where you are at every moment of every day. And sometimes that can even shift it, just trying to bring humour into the situation. But no, I mean, it's sad, isn't it? But I think it's going to be a growing problem, not only in vaccination, but in all areas of healthcare. I'm increasingly getting people telling me that I don't know what I'm talking about, and that's not just at home.
Okay, thank you for that. That was helpful.
Thanks, Chris. Any other comments or things people would like to raise? I don't know if anyone from Portsmouth or Surrey or Oxford or any of the other places that have already mobilised want to say anything at this stage? Or equally, those that haven't mobilised, is there anything you're kind of having trouble with that you want to kind of unpick a little bit?
I would just say for people who haven't mobilised but are looking at doing so, the important relationships you need to develop are with whoever holds the vaccines. So whether that's a local PCN or local vaccination service, you just need to make sure that that you know who's holding the vaccines and they're prepared to just drip feed you them as you need them, rather than making you suddenly react to them having a few spare. We shouldn't be getting the dregs at the end of the day, but we should be supplied with sufficient to do our job. So you need to develop that relationship, and then you also need to have an idea of who your team is to deliver the vaccine, and you need an idea of who your team is to actually do the organising beforehand and ringing around and working with local services. So those are the three things I'd say you need to focus on.
Brilliant, thanks Tim. Fab. If there's nothing else that people want to say, please do make sure you connect up with your local health colleagues. Make sure you know, as Tim said, where your local vaccination services are, where you get your vaccines from. If you've managed to sort out that spreadsheet so that your local vaccination leads can help in terms of the estimated numbers, so they know how many vaccines you need, that would be fab, and we'll certainly support that. If you want us to connect you up with anybody in terms of learning more about how others have mobilised, then please do come back to us. and we're very happy to do that. And as Karen has said, there are links in the slides that we'll share if we haven't already, with resources in terms of around reluctance to take up the vaccine and things like that. Andy?
Hi. Reluctant to jump into the lion's den, but if it's going to save everyone a couple of dozen emails later on in the day, I'm happy to take any questions concerning the that now infamous spreadsheet that's been sent out from more than one direction. Or if you'd just like me to clarify what's happening with it, why it's gone out, where we are with it, I'm happy to do that. I know everyone's busy, so if it will save later work, let's thrash it out now.
That'd be wonderful. Thanks, Andy. Any questions for Andy on the spreadsheet?
Great, I'll expect all the returns by tomorrow afternoon. Wonderful.
Sorry, can I just come in, Andy?
Yeah.
Okay, so this infamous spreadsheet, is that something? I'm just wondering, is a lot of that data, because there was a question I posted on just on the chat there around potential duplication with or people being doubly invited who are already registered with practices, because some homeless people are registered with practices and the practices obviously will invite them through the normal route. Now, obviously, we understand there's challenges there, okay? But I'm just wondering, in terms of the data pickup, is there some data that is already can be pre-populated from the numerous data that we have flying around the system?
Yeah, the spreadsheet that appears to have come from one direction, the one that came from health, or went by health, is populated with some sites. The one that seems to have come through the kind of local government type of route is blank. So yes, there is one which is populated. I'm quite happy to share that. But I think there wasn't supposed to be two separate requests. I think it originally came down through health for whatever reason, and then a separate request or an acknowledgement that this work was going on came through a different route. And really the message within that should have been, you need to be aware that health are looking at this. You guys know the information, you have the contacts, you're very close to the individuals who we are trying to make contact with, offer the vaccination to. So you need to work together. Whereas I think what's happened is it's seen as two separate bits of information, and there's concern about duplication. We're happy, or Sam and I, not Sam, Sam's about to go on holiday, so I'm happy to take any information that comes from whichever source it is and route that up to the national team, who will then have to go through duplicate information, etc. And I think I just feel happy. I prefer to get three emails with the same information on than three people believing that somebody else is going to supply that, and we miss out on a site or an individual. It doesn't matter. Everyone's important. So please don't worry about overloading my email, my mailbox. I'll just pass it on up to the national team and they'll sort out duplication. If it would help to have the original that I've seen, which lists all the sites, I'm happy to send that out.
I just wonder whether or not, because I mean, one of the things I've done is to kind of ask my local authority colleagues to kind of check the site and make sure that these are sites that obviously they're aware of. But yeah, I think sometimes I think one of the previous speakers spoke about the kind of previous relationship. I think having that close collaboration with our local authority colleagues in the first place, so that we are actually, these are information that we should actually be, to be fair, we should already working closely with our local authority colleague. We should already know this information pretty much, and so we shouldn't have to wait for a pandemic to kind of suddenly get us panicking, you know.
Yeah.
But you know, with all good intention, these things never happen the way we envisaged they would happen. So, but yeah, I mean, anything you can share, because sometimes I think the reason why I talk about the if there's information that's already gathered, is that sometimes, especially for areas who are starting from ground zero, sometimes it's better to take information that somebody's already put together and then to check whether it is valid, rather than to start from scratch, because then it takes forever to get anything meaningful. So that's why I'm suggesting that if there's information already there, which can be shared with the local teams, then actually we can almost like verify it, and in the process of doing that, we can maybe add to it.
Yeah.
Yeah, that makes sense. Candice has just said some clarity around the purpose would be helpful. Candice, have you had enough there of the sense of the purpose, or do you want a bit more?
I think so. I guess we were already working with local authority housing colleagues, and in some of the 3 areas that the Sussex CCGs covered. I mean, Tim's one of them. You know, the work has already happened, but we just won't have the information, I don't think. And we were given a deadline of last week, not tomorrow. But what we won't have is those visit dates and staff details, because staff have already been vaccinated through one of the other priority groups. So I guess it's just a point that we were already working with colleagues. We have been gathering this data anyway and are developing plans where we haven't already vaccinated people, but we won't have the information in the format that's requested, and just checking that it's okay to send you whatever we've got.
Yes, please do, because I'll pass it on to the national team, and they can pick the bones out of it. I think as far as the purpose is concerned, and I have to accept that Sam and I, this isn't really part of our role. We do very much, although it is very primary care, but we were involved with the care homes and the homes for learning disability, mental well-being, etc. Is that, my background is primary care, so I don't speak with very many of the regional phrases that I should be speaking with. But I think it's the fact that somebody has to stand up at some point, as they did with the care homes, and give assurance to the population that everyone in a care home, and this happened at the beginning of February, has been offered a vaccination. And the same assurance is going to be requested for the homeless. And it's how do we obtain that assurance? Personally, I think that a spreadsheet is probably not the tool, but that's the one that we've been given. But I think that the whole purpose of it is, how do we, as a system, and that's everybody within it, identify, communicate with, offer and vaccinate those people who wish to take up the offer based on an informed decision, and then how do we pass that assurance back up the line to the people who will stand in front of the podiums in 10 Downing Street at some point and say, we have offered vaccinations to all of our homeless. And that's the challenge between the reality on the ground and politics.
Yeah, I agree. Is that okay, Candice?
Yeah, that's helpful. Thank you. We'll do what we can.
Sorry, it's Tim here again. I would just say it's intensely frustrating, because if they were really interested, they could have let us do it earlier and started collating information earlier. Absolutely. And I don't think we should bend over backwards to make their lives easier, really. And because it was oversimplifying something that oughtn't to be oversimplified. Yes. And even just saying that, guaranteeing that every homeless person is offered a vaccination, well, what does that mean, given that people are becoming homeless, by the thousands every week, and then being moved into emergency accommodation, then on and on. And so I think it's fair enough to give broad brush figures for what we've managed to do, but I don't think we should be seeking to give an opportunity to people to stand up somewhere and say, aren't we wonderful, we've ensured that everyone who's homeless has been offered a vaccination.
Yeah, and
I'll get off my soapbox now.
the numbers are going to change from week to week, aren't they? So
yeah. And I think that's why, my point is that a spreadsheet is not the tool, because it is a very transient, it's a very chaotic population. And like you say, just because somebody is somewhere one day doesn't mean to say they're going to be there either the next day, or certainly not 10 to 11 weeks later on when you want to give them a second dose. Yeah. And I recognise that this work's been going on. really since the inception of the programme.
Yeah.
You know, outreach as a topic has always been on the planning grid. It's just how we deliver it.
Absolutely. Gillian, did you want to come in?
Yeah, sorry, I was on mute.
That's all right.
I think, you know, the other group that we've potentially got some real issues with are the people who have been placed in some areas across the southeast under the kind of overspill, which is a horrible word, and the dispersal for the asylum seekers, where they're overcrowded in the registered initial accommodation centres, because some of the group are very, you know, kind of very transient. Some people have been moved with very little notice, sometimes less than 24 hours. And the CCG area that were hosting them are not necessarily informed where they're going, so that you can make sure that there's that follow-up. And I think that's a real area that we might need to try and focus on.
Yeah, definitely. There's a whole area around those with no recourse to public funds generally, but that's a particular issue as well, that those that have been moved quite rapidly from one place to another. Olivia, we probably need to pick that up outside as well.
Yes, will do.
I'm just wondering whether or not it's really wonderful that that we are focusing on this population group because of COVID, and I just wondered whether or not whether we could utilize this opportunity to actually look at how we because the strategies we are adopting now to reach our homeless population. It's arguable the strategy we should be identifying to be reaching them every day of the week, not necessarily just whenever there's a pandemic. So I'm really worried that yes, we're doing this now, but actually we're then going to go back to normal, and we're going to lose the passion, the desire we have to make sure that we're taking health care to our homeless population.
Absolutely agree.
I just hope that we don't lose that momentum, because that would be really sad, I think.
Yeah, no, absolutely agree. And members of this network have been really pushing for that all year, and working to try and make sure that that doesn't happen. And hopefully we'll continue to do that as we move forward with the network over the next 6 to 12 months as well. So totally agree. Right, I think we will just quickly move on now. We don't have much to update on from the wider perspective, but we will just draw that to a close there. So as I said, we've got we've brought together all of the different resources around vaccinations and things for you into one place, so that you can have those to hand as you need, and they'll be in the slide set for you. And there's, do you want to mention that, Olivia?
Sorry, still on mute. So we're organising a workshop on vaccination next week, which will focus essentially on reasonable adjustments and issues of consent. That's come about from some of the designated nurses and some of our colleagues in learning disability, in particular for people who might have a not a severe learning disability and therefore live in supported accommodation and not be flagged as needing some reasonable adjustments, but also for people with serious mental illnesses. So if anyone is interested in joining the workshop, we will record it. Please do send us an email at the generic email address there, and we'll send you an invitation.
Lovely, thanks, Olivia.
Is that supposed to say 31st of March on the sheet? Sorry.
It should do. Thank you for.
Okay, sorry. It wasn't just me. Okay.
Thanks. Yeah. So.